Okay, so today we have the anesthesia and perioperative care section from the critical care topic. Okay, so this is your first scenario. Kindly review it and then we will start with the station.
Yes, sir.
Okay, so going through the scenario, what are your differentials?
Sir, this is a case of lobectomy and is on thoracic epidural analgesia. So this would be a side effect due to lobectomy as well, and an adverse effect of the thoracic epidural analgesia. Regarding the lobectomy, it can be a hemothorax or pneumothorax following the surgery. And it can be a hypotension. There can be a hypotension, but since the patient is having bradycardia, it is ruled out. And if the epidural analgesia is given higher up, that can also lead to the decreased respiratory rate.
Okay, so why the patient is having bradycardia?
Because the cardiac fibers could be affected, which are the sympathetic fibers, due to the higher level of epidural analgesia, leading to over action of the parasympathetic nerve fibers and leading to bradycardia.
Okay, so what will be your management plan for this case?
Um, I will first inform the consultant surgeon and the anesthetist. And I will start the patient on 100% oxygen. I will monitor the patient's pulse rate and BP and the um, saturation. The saturation is 88% at present. I will keep the patient in a right position. Um, I will also stop any epidural analgesia if anything ongoing. And I will start the patient on inotropic supports and vasopressin. Inotropic supports like epinephrine and epinephrine.
Okay, so what are the factors which
Yes,
affect
sir.
epidural efficacy?
Factors of epidural efficacy can be from the patient side, the procedure side as well. From regarding the patient side, it could be factors like age, height, and weight. Regarding the procedure factor, it can be due to the position of the patient where the uh, is being inserted. Then the dosage of the medication, the type of drug that is given, and the level at which the epidural analgesia is given.
Okay, so why epidural is chosen in this case?
Since it is a case of lobectomy, the patient requires adequate pain control following the surgery. Hence, thoracic epidural analgesia is given.
Okay, so how can you test for the level of the block in this patient?
The level of block can be tested either by using Either pain or temperature can be tested, but most probably temperature is tested more than pain because pain it can lead to the triggering of increased pain or bleeding. But when you are testing temperature, we can test it with ice packs or with ethyl chloride spray. So that if we keep ice pack or if we spray the ethyl chloride, the patient will can feel there is no sensation. So the patient will say there is no sensation at that level, and that is how we know the level of the block.
Okay. So how can you differentiate between a high epidural block from hypovolemic shock?
In hypovolemic shock, there will be tachycardia and there will be cold and clammy extremities. But in epidural block, there will be bradycardia and the extremities will be warm and pinkish.
Okay, so can you elaborate some of the systemic effects of epidural analgesia?
Uh, mm, the epidural analgesia, in the cardiovascular system, it can lead to decreased heart rate and hypotension. In the respiratory system, it can lead to respiratory depression. In the GIT, it can lead to vomiting or nausea, in or constipation. It can also lead to um, decreased mobility and DVT. In the cardiac, we can also include MI. They can also lead into MI. And in the kidneys, it can lead to oliguria or decreased urine output. Then, yeah, that's it. So
Okay, so what
it can
sign?
also,
Yes,
yeah, can I complete, sir?
yes, yes.
The patient can also have an anaphylactic reaction by release of histamine, leading to itching or yeah, itching. Yes, sir.
Okay. So what sign and symptoms would tell you that the patient is getting worse in this scenario?
Uh, in the in this scenario, the signs are decreased saturation. The saturation is only 88%. The heart rate is there is a frank bradycardia. The pulse rate is only 45, and there is BP hypertension. Since the BP is only 70 by 40. Then regarding the mm, that's a science, sir. Yeah.
Yes, basically the purpose of this question is to elaborate the basic things like heart rate, blood pressure, urine output, sensations, GCS, and
Okay.
like things like that. Okay, so when the blood
Okay, sir.
pressure is decreasing, when the heart rate is decreasing, when the oxygen saturation is decreasing, when the patient is having a
Yes, sir.
decreased urine output. So these will be the features
Yeah,
that
no,
will
okay.
show that the patient is
Okay,
getting
sir.
worse.
Okay, sir.
Okay, so rest of your answers were pretty much to the point. So you did the session well. So
Thank
next
you,
we
sir.
have this scenario, kindly review it and then we will start.
Okay, sir. Yes, sir.
Okay, so the patient has been provided with two 250 ml boluses with small improvement. Can you elaborate the fluid chart on the basis of this?
Yes, sir. This is a post-operative patient. So, two fluid challenges of 250 ml is not enough in this patient. So, the fluid, there is a likely chance of decreased intravascular volume in this patient. So, it is not adequate, sir.
Okay. So how will you manage this case?
So first I will give a fluid challenge to this patient with 250 ml bolus. The maximum times that I can give a fluid challenge is 4 times. And then I will look for any improvement. The fluid challenge is both diagnostic as well as therapeutic. So giving the fluid slowly will not stretch the cardiac, will not stretch the heart. So that can help in restoring the intravascular volume, hence helping in therapeutic means. So I will manage the patient by giving IV fluid challenge, and if needed, I will start the patient on inotropic drugs like epinephrine or norepinephrine or any vasopressor agents. And I will also look for any evidence of hemorrhage in this patient, like internal bleeding, since it is a post-operative case. I will also monitor the pulse rate, pulse rate, BP, and capillary refill, and also the urine output.
Okay, so what is the formula of fluid challenge?
Uh, the cardiac output into the systemic vascular resistance. So cardiac output is stroke volume multiplied by heart rate.
No, formula for fluid challenge, not blood pressure.
Uh, Formula for so it is 10 to 20 ml per kg.
Yes.
So in cardiac patients we can give 5 ml. In normotensive patients we can give 10 ml. In hypotensive patients we can give 20 ml per kg.
Yes. So the patient is on 2 hourly monitoring. Is this monitoring adequate?
No, sir. We can give hourly. We should do hourly monitoring in this patient with respect to heart rate, BP, and capillary refill and urine output.
Okay. So how will you manage this patient after providing him with the fluid challenge for the remainder of your shift?
Mm. I will inform the consultant surgeon, and I will also involve the anesthetist. Yes.
Okay. So who will you notify and when specifically will you notify them?
If the patient is not improving on fluid challenge, I will notify the uh, consultant surgeon. There
After
could be a risk of hemorrhage
after how many fluid
uh,
challenges?
after 4 fluid challenges.
Yes. Okay, so what is the formula for calculating blood pressure?
Blood pressure is cardiac output into systemic vascular resistance. So the cardiac output is stroke volume into heart rate.
Okay, so by what measures we can increase the blood pressure of the patient?
We can give IV fluids to the patient. We can also start the patient on inotropic supports like epinephrine and norepinephrine, and also give the patient vasopressor agents. We can look for any hemorrhage and try to stop the bleeding. Um, yes.
Okay. So what is the hormonal response to surgery and trauma?
So there are particular hormones that are increased, decreased, and unchanged. So the hormones that are increased following a surgery are glucagon, growth hormone, adrenocorticotropic hormone, antidiuretic hormone, cortisol, renin, and prolactin. Then there are testosterone, estradiol, and insulin is decreased following surgery, and luteinizing hormone, follicle stimulating hormone, and thyroid stimulating hormone remains the same, unchanged.
Okay, so what are the mechanisms by which kidneys increase the osmolarity in the renal medulla?
In the loop of Henle, from the mm, from the descending limb of loop of Henle, water is reabsorbed from the tubules into the renal medulla. Then, from the ascending limb of loop of Henle, sodium ions, sodium chloride moves from the tubules into the medulla. So this increases the gradient, hence resulting in increased absorption of water from the descending limb with the help of countercurrent mechanism. So that is how it increases the osmolarity in the renal medulla.
Okay, so what is the mechanism of action of antidiuretic hormone?
Um, Antidiuretic hormone helps in retention of salt and water. It also does vasoconstriction. Um, it also results in contraction of the mesangial cells, resulting in decreased GFR. It also inserts aquaporin channels into the collecting ducts, hence resulting in increased water reabsorption, solute-free water reabsorption. Then it does not increase uh, it does not pass through the blood-brain barrier. Um, mm, yeah, so
Okay. So what are the actions of renin, angiotensin, aldosterone system?
in renin-angiotensin-aldosterone system, the renin activates angiotensinogen to angiotensin 1, and angiotensin uh, 1 is converted into angiotensin 2 by angiotensin converting enzyme. The angiotensin 2 helps in the release of ADH. It also helps in increasing the blood pressure by vasoconstriction, increasing the systemic vascular resistance, and also increasing the um, cardiac contractility. And also, it helps in stimulating ADH secretion, resulting in decreased diuresis and increased salt and water retention.
Okay.
Awesome.
Okay, so you did this station very well.
Thank you, sir.
So just keep this up and keep practicing.
Yes. Thank you, sir.
Okay, so okay, I guess I forgot to add the pain management scenario. We will just continue with it. Okay.
Okay, sir.
Okay.
Mm,
So how will you manage the patient who is having severe pain?
okay. This structure. So we will manage the patient by certain pain scale means, and also with the help of patient-controlled analgesics.
Okay. So what will be your immediate management?
I will classify the severity of the pain, whether the pain is mild, moderate, or severe. And there are certain pharmacological and non-pharmacological measures. I will check if there is any ongoing medications for the pain for this patient, if there is any SOS medications. So if the patient's pain is mild, so can I explain it?
Yes.
Okay. If the patient's pain is mild, I can either give paracetamol or NSAIDs. If the patient's pain is moderate, I can give mm, paracetamol and plus NSAIDs. If the patient's pain is severe, I can start with um, IV, IM or subcutaneous painkillers in CID with paracetamol, then opioid, and IV, IM or subcutaneous opioids with paracetamol with NSAID or epidural analgesia.
Okay. So, what are the side effects of giving opioids to the patient?
Side effects are the patient can go into respiratory depression. There is decreased mobility, decreased level of consciousness in the patient, decreased urine output, and increased risk of ileus and constipation. There can also be any side effects like pruritus or itching following administration of opioids.
Okay. So, can you elaborate what is the pain pathway?
Yes, sir. The pain is carried into the brain with the help of lateral spinothalamic tract. The pain fibers are A delta and C fibers. A delta is for sharp pain and C is for slow pain. It is conducted and through these fibers, and then in the spinal cord it crosses over to the opposite side, crosses over the midline, and then ascends to the ventroposterolateral nucleus of the thalamus. And from the thalamus, it radiates into the somatosensory cortex where the pain is perceived.
Okay. So, what are the pain assessment methods that we can use?
We can use visual pain analog score, the VPA scale. So there will be certain phases. From the phases, we can identify. We can ask the patient to identify what. We can identify from the patient's face the severity of the pain. We can also give the patient a particular scale from 0 to 10, and where 0 is absent pain and 10 is worst possible pain. And for children, we can also use the Baker scale. Faces, it's a faces scale. Uh, so those are the measures.
Okay. So, can you elaborate what is patient-controlled analgesia?
Patient-controlled analgesia uh, mm, is controlled by the patient themselves. There is a infusion syringe pump where the particular opioid or analgesia is going on. The patient can adjust dose uh, with the control in with him. So the patient has to be conscious at that time and a very well cooperative patient to use the patient controlled analgesia.
Okay. So, what is the normal dose of morphine which is used in the patient-controlled analgesia?
0.5 to 2 milligrams.
Okay. So, can you elaborate what problems can happen with patient-controlled analgesia?
Uh, there can be overdosage, but there is a lock system to administer particular dosage only in particular period, and the dose cannot be repeated within certain time period. And so overdosing can also be blocked with the lock system. Then the patient can go into decreased mobility, decreased consciousness. So the patient may not be able to manage the PCA by himself. There is also risk of DVT. There is also risk of chances of wound complications and decreased respiration. There can be a risk of atelectasis, decreased heart rate, decreased blood pressure, and decreased capillary refill. And there is decreased urine output oliguria, and a patient can go into ileus due to decreased mobility. Yes.
Okay. So give examples of the opioids which are in common use.
The opioids can be divided into non-synthetic, semi-synthetic, and synthetic. The non-synthetic are morphine and codeine. Semi-synthetic are diamorphine and dihydrocodeine. And synthetic ones are pethidine and fentanyl.
Okay.
Yes,
Right. So you did this session very well. So
thank you,
that's
sir.
it. So any
Mm.
questions for today's session?
Sir, in the why don't we give why we just start with the inotropic supports and vasopressor agents in epidural anesthesia complications? Why don't we first give fluid challenge like there is fluid challenge given,
Mhm.
but why only fluid challenge? Why don't we give a fluid resuscitation like?
See, epidural is a type of distributive shock. Okay. In
Okay,
that, there is peripheral vasodilatation with adequate fluid that is present previously in the body.
okay, okay,
So there is no problem with the fluid, but the vessels
okay,
have dilated, their area have increased, so they will have pooling of the fluid. So we
okay,
need
okay,
the heart to push fast and
okay,
vasoconstriction in the periphery. So
okay,
that
sir.
is why
Okay,
we start with the inotropes in epidural.
okay, sir.
Whereas in hypovolemic shock, the pathophysiology is that the fluid is lost, whether it's a diarrhea, sweating, hemorrhage, external bleeding, or anything. So we have to replace the fluid. So the ideal for that is blood, but in the meantime, we
Okay,
continue with the fluid, whatever the amount of fluid we can give to the patient.
okay, sir. Okay, thank you, sir.
You're welcome.
Mm.
Okay, so we'll continue with the anesthesia and the perioperative care.
Yes, sir.
Okay, so first of all, we have the post-tonsillectomy bleeding station. So kindly review the
Okay,
scenario and then we will start.
okay. Yes, sir.
Okay, so how will you manage this patient?
I will manage the patient according to the pediatric resuscitation protocol. I will first uh, keep the patient upright. And should I tell you the details, sir? Like the airway, breathing, circulation?
Yes, explain the details.
Yes. Yeah. Okay, sir. So I will first check the airway for any foreign body or blood clots. Like in this case, there is any blood clots, I will try to suction out the blood clots. And if I will make the patient sit upright, and I will motivate the patient to not to swallow the clots and to spit the clots out. And I will check the breathing level, and I will give oxygen support. And I will also check the circulation by measuring the pulse rate, the capillary refill, the BP, and the mental status, the GCS. And mm, if needed, I will give chin lift and jaw thrust, and I will also insert an airway if there is any airway compromise, or a pharyngeal or nasopharyngeal airway, and I will inform the anesthetist and also the ENT consultant.
Okay, so patient's HB is 7.8. So what will you consider?
Since the hemoglobin level is less than 9, I will consider a blood transfusion for this patient. And I will start the patient I will ensure the patient is having two large bore IV cannulas. And if there is any hypovolemic shock, I will start with IV fluid resuscitation. And since the hemoglobin is 7.8, I will give blood transfusion.
Okay. So if the HP is 7.8 and the parents of this child are Jehovah's Witness, does that change anything in your management?
Mm, since they have the tradition of not accepting blood transfusion as a part of their religious belief, if the 9-year-old is stable, then I will wait and I will not transfuse blood. I will wait, and I will also wait for the consent of the parents to start blood transfusion. If they are not willing, or if the child becomes unstable, I will inform the related consultants, and also I will acquire legal support to give blood transfusion to this patient.
Okay. So what if bleeding does not stop despite the above measures that you have taken? So what else you will consider in the management of this patient?
I can give tranexamic acid, 10 to 15 milligrams per kg body weight. And I can also do the posterior nasal packing, like inserting a Foley's catheter through the nasal cavity, and then tying a pad to gauze, and then giving pressure to the posterior, to the tonsillar region. So that, sorry, sir, I was confusing with the adenotonsillectomy.
Yes.
For tonsillectomy, we can actually place Surgicel. Surgically, we can place Surgicel. We can also do underrunning sutures. We can also give pressure to stop the bleeding. If under any measures, if the bleeding is not stopping, then we can ligate the external carotid artery, or we can go for embolization of the external carotid artery.
Okay.
Yes.
So what type of diathermy can be used?
Bipolar diathermy.
Okay. And would there be anything specific that you will like to perform before extubating this patient?
Since the patient would have swallowed some clots, I will first insert a nasogastric tube before extubation, so that I can suction with the help of the NG tube.
Okay. So can you tell me in short that what are the three parameters which are used in the WHO checklist?
Uh, Sign in, time out, and sign out.
Okay. So you did the session well. So basically you were
Thank you,
not
sir.
confusing. Basically this bleeding is from a tonsillectomy. Okay. So
Okay.
basically they are all the measures to stop bleeding will apply on this case as well.
Okay.
Okay.
Okay,
So
sir.
like you will
Okay.
be using good
Yes.
hemostasis. For that, you can use
Okay.
pressure. You can use diathermy. That will be bipolar diathermy. Then if still bleeding
Okay.
is not stopped, you can go with the underrunning of the suture. And then
Okay.
you can also give the patient transexamic acid. Like these are the measures
Okay.
which we take whenever we encounter bleeding anywhere.
Okay, sir. Thank you, sir.
Okay, so this is your next scenario. Kindly review it and then we will
Uh,
start.
Okay. Yes, sir.
Okay, so why this patient is not fit for epidural?
Um, Since this patient is a COPD patient, the epidural anesthesia, if you give a high epidural anesthesia, the patient may not be able to take proper respiration. And there will also be decreased drive for respiration, which happens in COPD patients. So this patient is hence not fit for epidurals.
Okay, so why cannot we give morphine to this patient?
Morphine also causes respiratory depression. In the consciousness is a very important thing in the patients with COPD. So, when the carbon dioxide, increased carbon dioxide leads to a respiratory drive in COPD patients. So, in that time, the patient may not be able to breathe properly if morphine is given, since it does respiratory depression. The patient goes into respiratory depression.
Okay. So what are the different types of anesthesia apart from epidural which can be useful in this patient?
We can give regional block uh, and local anesthesia, regional block, and general anesthesia.
Okay. So how can you manage the patient's pain post-operatively?
Post-operatively, we can give either NSAID or paracetamol, and if there is severe pain, we can also go for local anesthesia. And mm, yes, we can give IV paracetamol also.
And
Mm,
okay. So what is
yes.
the maximum dose of bupivacaine that can be used?
2 mg per kg.
Okay, so how many milligrams of bupivacaine in 10 ml of 0.25% concentration?
Uh, 10 ml. 10 ml contains 25 mg.
Yes. So can you tell me what are the manifestations of local anesthesia toxicity?
There can be systemic toxicity and neurological toxicity as well. In systemic, the patient can go into confusion. The patient can have headaches, and also the patient can have seizures. There can be bradyarrhythmias, hypotension, decreased hypertension, and the patient may go into MI. Uh, mm, there could be perioral numbness. Then there can also be hepatotoxicity, and if there is any accidental injection into the blood vessels, it can cause bradyarrhythmias.
Okay, so what are the factors which enhance the local anesthesia toxicity?
Low cardiac output states, high cardiac output states, and hepatotoxicity. Then drugs such as beta blockers, then calcium antagonists, cytochrome P450 inhibitors, and digoxin. Mm, yes, sir.
Okay. So how can you revert local anesthesia toxicity?
We can give lipid emulsion therapy with intralipid 20 percentage at a dose of 1.5 mg per kg, then bolus followed by maintenance infusion.
Okay, so is there any specific step that you can take to prevent local anesthesia toxicity from happening in a patient?
While injecting the local anesthesia, we have to aspirate and check whether if there is blood in the syringe, which means we have entered a blood vessel, so that we can prevent injecting the medicine into the blood vessel.
Okay, so you did the answers very well. And just one thing
Yes.
to add, that how to
Yes.
revert or manage the local anesthesia toxicity. You will say that I will manage this patient according to the CCRIS protocol using A to
Okay.
E approach. First of all, I
Okay, sir.
will make sure that there is no prominent abnormality that needs to be addressed. And after that, I will
Okay.
inform my consultant. And then specifically, if there are seizures present, then I will give diazepam, that is a benzodiazepine. And to
Okay.
specifically use the antidote, I will give the intralipid infusion.
Okay,
So
sir.
that will cover all the things which are
All the
related to
aspects.
the management.
Okay, sir.
Okay, so this is all
Mm.
for today.
Okay, sir.